بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله. I'm Nazik Elmalaika, a professor of pathology at the Faculty of Medicine of Durman Islamic University. It's of my pleasure to welcome you and discuss with you today's lecture about hyperparathyroidism. In this short lesson, we are going to review the calcium metabolism and the differential diagnosis of hypercalcemia. It is important because hyperparathyroidism is associated with high calcium level. Then we are going to discuss see the parathyroid gland, its histology and functions, and its relation to the parathyroid hormone. We are going to touch hyperparathyroidism, the three types, and its pathophysiology, and only mention the treatment options and present one case. As you know, calcium is an essential intracellular and extracellular cation. As extracellular, it is required to maintain normal biological function of the nervous system, the musculoskeletal system, and the blood coagulation system. As an intracellular cation, calcium is needed for normal activity of many enzymes. It is also important for the preservation of the integrity of the cellular membrane. It regulates the endocrine and exocrine secretory activities and activates the complement system. It is very important in bone metabolism. To summarize the role of calcium, it is essential in bone mineralization, in the muscle contraction, in all types of muscles, whether skeletal, cardiac, or smooth muscle, and hence it is essential and discussed in this course, musculoskeletal system. It is also important in the blood clotting system and the nerve impulse transmission. The calcium is regulated through the hormone, parathyroid hormone, and the calcitonin hormone, in addition to the vitamin D. With these hormones, it plays play as seen in the right image. And the organs responsible for this homeostasis are bone, kidney, and the small intestine. In addition to dietary input of the vitamin D can be absorbed from the sun UV light and changed in the skin from raw vitamin D to vitamin D. Then it goes to the liver together with the vitamin D from the dietary intake, where it is where 25 hydroxyvitamin D is formed. Then it goes to the kidney, where it becomes an active 125 dihydroxyvitamin D. From there, it can reabsorb to go bones or intestine. In the bones, calcium stores are mobilized according to requirements. Also in the intestine, there is increased calcium and phosphorus absorption. Together, they maintain the serum calcium and phosphorus functions, which are the metabolic functions, bone health, and neuromuscular functions. As we said, the small intestine, the kidney, are essential for calcium homeostasis. Approximately 40% of the calcium is absorbed in the small intestine. 50% of this excreted into the bile and other intestinal secretions. So only 20% of the total amount of calcium ingested daily is available to circulate between bone and extracellular fluid. And in the kidney, the glomerulus filters out the calcium that is not bound to protein. In the proximal tubules, approximately 50 to 70% of the calcium is reabsorbed. And in the ascending limb of the loop of Henle, approximately 30 to 40% reabsorbed. And in the distal nephron, about 10% is reabsorbed. The parathyroid hormone and the activated vitamin D increases calcium absorption during calcium deficient states. Normally, kidney excretes about 200 milligrams per day of calcium to maintain homeostasis. And during states of severe calcium depletion, the kidney can decrease urinary excretion to 50 milligrams per day or less. This diagram shows or summarizes the relationship between the parathyroid hormone, vitamin D, and calcitonin, and their role in the regulation of calcium levels. The parathyroid hormone, which is secreted from the parathyroid gland, and the active form of the vitamin D formed in the kidney have positive impact on calcium. They increase calcium in the extracellular fluid, and this is by resorption from bone, increasing its absorption from the GIT. So the extracellular fluid pool of calcium is increased. Also, they increased the reabsorption from the renal tubules. However, the calcitonin has a negative role with the parathyroid hormone and calcium. Okay? When calcium levels increase, the calcitonin, which is produced from the thyroid gland, parafollicular cells, gives a negative control to the parathyroid gland to stop the parathyroid hormone secretion. These are the parathyroid glands. They are 4 small glands, less than 1 centimeter each, about 6 times 3 times 2 millimeters, located behind the thyroid in the neck. Often, accidentally, they are removed during thyroidectomy. However, if only 2 glands are there, their function is enough. Histologically, this is the parathyroid gland, which is composed of chief cells, the cells which are responsible of the synthesis, secretion, and storage of the parathyroid gland, and oxyphil cells, the function of which is unknown till now. The parathyroid hormone is responsible for the calcium homeostasis, as we said earlier, in the kidney and bone. The parathyroid gland or parathyroid hormone increases calcium. It regulates its intestinal absorption. It increases the absorption of calcium in the small intestine. It also forms the active form of vitamin D from 25 hydroxyvitamin D to 125 hydroxyvitamin D in the kidney. It increases the renal absorption of calcium and excretion of phosphorus in the kidney. It causes bone resorption through osteolysis. In the bone, the osteoblasts and the osteocytes together form the osteocytic membrane system. This system has a pump which is called osteocytic pump, like the sodium-potassium pump. This pump pump calcium from the bone to its extracellular fluid. To maintain calcium concentration in bone fluid, osteolysis occurs and calcium phosphate is resorbed from bone. However, the fibrous and gel matrix remain intact. The parathyroid hormone stimulates osteocytic pump. It increases the permeability of osteocytes membrane, allowing calcium to diffuse. The osteoblasts, the osteocytes and clasts do not have parathyroid receptors. Instead, the parathyroid hormone stimulates osteoblasts and osteocytes, which then activate osteoclast via a signaling system. The parathyroid hormone indirectly stimulates formation of new osteoclasts, and both cell lines are activated. However, the clastic activity is more than the plastic one. The calcitonin is a hormone secreted by the parafollicular cells. Here, this is a parafollicular cell. Why these are the follicular cells from the thyroid gland? It temporarily lowers calcium levels. It decreases osteoclastic activity. And it is stimulated by high calcium levels. That is to say, high calcium levels stimulate the production or secretion of calcitonin from the parafollicular cells. This is a negative feedback. It stimulates a distal tubular mediated calciuresis to reduce or to excrete the calcium in the urine and reduces its level in the blood. The importance of the parathyroid gland hormone is that it causes most of the cases of hypercalcemia. Hypercalcemia is a serious and important issue or disorder. About 80% of all cases of hypercalcemia are caused by malignancy or primary hyperparathyroidism. And in this slide, you can know the other causes of hypercalcemia, which are vitamins, immobilization, thyrotoxicosis, Addison's disease, milk alkali syndrome, inflammatory disorders, neoplastic-related diseases, sarcoidosis, drugs like thiazide and lithium, rhabdomyolysis, AIDS, Paget disease of bone, perinatal nutrition, pheochromocytoma, and parathyroid disease. So when you encounter during your clinical practice a high level of calcium, more than 10.6 milligrams, you have to determine first whether this is a true hypercalcemia or not. You have to measure the ionized calcium and adjust for the change in serum albumin level and take a careful drug history. Is the patient taking lithium or vitamin D or vitamin A that can cause hypercalcemia or not? If it is a real hypercalcemia, then measure the parathyroid hormone. If it is raised, this is hyperparathyroidism. In any case of hyperparathyroidism, there is a high level of parathyroid hormone. If it is normal, then or low, then This could be, or this hypercalcemia could be due to a malignancy. As we said, hyperparathyroidism and malignancy form or cause about 80% of cases of hypercalcemia. If cause remain unclear, then measure vitamin D. If it is high, consider sarcoidosis and do a chest X-ray. If it is not, then consider other causes of hyperparathyroidism, putting in mind the rare milk alkali syndrome and familial hypercalciuric hypercalcemia. This is the clinical importance of hyperparathyroidism. Hyperparathyroidism causes stone or predispose the patient for stone formations, commonly renal stones, but also bile duct stones and other sites. And stones can be formed in other sites of the body. It causes bone aches, pain in the bones. It causes groans and moans. The patient is always complaining of fatigability, of feeling ill, feeling unwell, and so on. And this is because there is increased resorption from the bone, as we said earlier. The increased resorption from the bone causes it to be fragile, can easily be fractured, pain in the bone, and feeling unwell. This is in the right side of the slide. This is the bone in hyperparathyroidism. These two tables are very important. The above one summarizes the three types of hyperparathyroidism, and the lower one, the causes of hypercalcemia and how to differentiate between hyperparathyroidism and malignancy as a cause of hypercalcemia. In the upper table, hyperparathyroidism can be classified into three types: primary, secondary, and tertiary. Primary is usually caused by a parathyroid adenoma or hyperplasia or rarely malignancy or endocrine malignancy. And in primary hyperthyroidism, there is usually hypercalcemia, but the parathyroid hormone can be normal or increased. The secondary hyperparathyroidism is totally different from the primary. It is associated with chronic renal disease and low vitamin D levels. As being hyperparathyroidism, the parathyroid hormone is increased, however, the calcium is low or normal. While the tertiary hyperparathyroidism, which is a consequence of long-standing or chronic secondary hyperparathyroidism, the parathyroid hormone is very high and the calcium also is high. In the lower table, as we said, 80% of the cases of hypercalcemia are due to either to hyperparathyroidism or malignancy. If it is caused by the primary hyperparathyroidism, you will find high parathyroid hormone. Which type? The intact parathyroid hormone. And you will find hypercalcemia and high level of vitamin D. If the cause is a malignancy producing parathyroid hormone peptide, which resembles the parathyroid hormone or mimics it, so interfere with its receptors, in this case, you will find a high level of parathyroid peptide, parathyroid hormone peptide and not the intact parathyroid hormone. The intact parathyroid hormone level will be low, while the parathyroid hormone peptide is high and the vitamin D is low. If it is a malignancy but not producing parathyroid peptide, then both the intact parathyroid hormone and the parathyroid peptide are low, also vitamin D, but still the calcium is high. Any malignancy can cause hypercalcaemia. This 8-minute YouTube video is very useful and it is available in the Moodle. I recommend it. I recommend you to watch it. Very useful video. Hyperparathyroidism can be treated surgically or medically. Surgically, we do parathyroidectomy. We remove the parathyroid glands, especially when there is adenoma, hyperplasia, or malignancy. But there are strict indications for this surgical management. The serum should be more than 12. The calcium should be more than 400 milligrams per day. Hypercalciuria in the urine. There should be signs and symptoms. The patient should be less than 50 years and so on. And medically, aldrinoid therapy is given, and usually for patients who are not eligible for surgery and common with primary hyperthyroidism. The most important thing is to treat hypercalcaemia, which is caused by hyperparathyroidism, because as we said, it is serious and causes many serious effects, even the cardiac arrest. And this includes hydration, furosemide diuresis, and bisphosphonate and other drugs, including calcitonin. This is a case presentation. A 52 years old African American female presents with broken hip, poor light exposure, fatigue, constipation, difficulty concentrating, history of kidney stones. These are the most common presenting symptoms of hyperparathyroidism. Elderly patient, most commonly, with fracture, pathological fracture, because of the weakened resorbed bones. Usually they have low or history of poor light exposure, being always indoor. Fatigability is a common symptom, also pain in the bones. Constipation, difficulty in concentration, and a history of kidney stones. Laboratory investigations showed calcium, 13 milligram, which is high, phosphorus, which is low, 2 milligram, and vitamin D within the normal level. And when we measure the parathyroid hormone, it is 90 picogram per mil, which is high. So this is a primary hyperparathyroidism. With this, we came to the end. I hope you find it useful. Wassalamu alaikum wa rahmatullahi ta'ala wa barakatuh.